Okay, so there are a few things you want to know about agonist, antagonist, and partial agonist. They're sort of terms that you're going to be hearing a lot about in your course of pharmacology, and it sort of is one of the basic foundations that you sort of need to understand. So as you can see on the left, you have the activity scale. So we'll say, at 100% activity, for example, you could have 20 millimeters of mercury drop in blood pressure. So you have a full agonist over here on the right. The full agonist asserts a strong effect and can reduce the blood pressure by 20 millimeters of mercury. On the other hand, you have an antagonist. It's important to remember the antagonist, it's not asserting a negative effect like the inverse agonist, but it is just blocking the constituently active receptor. So for example, your heart has receptors that are responsive to norepinephrine. That's sort of in balance with the other receptors that are responsive to acetylcholine, causing, a reduction in your heart rate. So it's important to remember that when you give somebody an antagonist, what you're really doing is you're blocking that constituently active, norepinephrine just, as it's physiologically released, binding to its beta receptor and causing tachycardia. So what you're doing is you're blocking it. So it slows, in this case, would, slow the heart rate by just blocking your normal physiologic activity. It's not causing a negative effect. One other thing that's a little bit more academic is the partial agonist. So the partial agonist, even though it's in between the antagonist and the full agonist when it comes to activity, it's almost acting as both. So there are a few of them out there, a few ones we see in pharmacology that you'll read about and talk about in the upcoming weeks, but it's important to understand that while there is a little physiological effect, I don't know, maybe on this chart specifically 30%, 40%, in reality it's also blocking some of the, as we talked about with the antagonist, is blocking some of the physiological release of, in this case we were talking about norepinephrine. So even though it has some sort of activity, it also acts as an antagonist. So that's just a key point you want to remember. When we talk about some of the other agents in the coming weeks, we'll sort of get into more detail about why specifically you'd want to use a partial agonist versus a full or an antagonist. So the way we describe the effects, let's say, of an agonist or an antagonist is efficacy and potency. It's very, very important to make sure you understand the difference between the two and what each is explaining. So efficacy is the maximum effect a drug can produce. So as we saw on the last slide, on the left, we have the maximum effect a drug can produce. The more efficacious drug produces a greater effect. So for example, drug B, as we talked about before in blood pressure, maybe drug B can only reduce a patient's blood pressure by 10 millimeters of mercury, whereas drug A can reduce the patient's blood pressure by 20. Now, the next thing is potency, and it's very important to be able to differentiate and talk about both efficacy and potency without confusing the two. They are not related. Now, they sort of are independently related, but they're not the same thing. Potency would be like saying you have two drugs, drug A and drug B. As we saw, we'll keep with the same scale. We have our maximum effect scale, and we'll say that it's blood pressure. So both drug A and B are able to reach a maximum effect that is very similar. They both can reduce the blood pressure, we'll say, by 20 millimeters of mercury. So if we go back to our previous concept, efficacy, they're equally efficacious. They have the same maximum effect. However, drug A, we'll say, takes 1 milligram to produce the maximum effect, whereas drug B may take 10 milligrams to create that same maximal effect. So while their efficacies may be similar, their potency is different. So for example, A is a more potent drug. Potency is the amount of drug that's needed for a given effect. And as you can see on the chart, that is represented as a leftward shift. A shift to the left indicates less of a dose of a drug. And then you can then see that looking at its maximum effect, it is still at a lower dose able to reach a similar efficacy. So, when you speak about these two terms, you do use them together. However, it's important to remember that efficacy is the effect that the drug can reach, whereas potency is the dose at which, that effect is reached. Very important to remember these two terms and, how they're different. Now, one of the more annoying things you're going to have to deal with is, of course, you have your drug and you have its effect, but as you know, questions are going to be asked about if you, change this or do that, how is the chart change? And this is sort of where a lot of the questions come, especially on the upcoming exam. So for example, we're talking now about enzymes. So A is sort of our agonist, I is our inhibitor. So for example, if you use a competitive antagonist, you've sort of gone over this in biochemistry. It's very similar to the enzyme kinetics. You're just sort of looking at it in a chart in a different way, because instead of looking at substrate and velocity, you're now looking at, pharmacological terms, the effect of the drug and then the dose needed. So for example, for the competitive antagonist, you have your agonist represented as A and I as your inhibitor, both acting on the same site. Therefore, it's an competitive. As you can see, as you increase the dose of the inhibitor, you are still able to reach a maximum effect of 100. However, it is going to take much more agonist to get there. So competitive antagonism does not change the maximum effect or the efficacy, but it does reduce the potency because you need more of the drug to exert the same effect. Now, pseudo-irreversible. Pseudo-irreversible is sort of similar to our allosteric type. Pseudo-irreversible, A is represented as our agonist and I as our antagonist or inhibitor. A way to describe this would be a suicide substrate, an inhibitor that binds to an enzyme, and once it binds, the enzyme is out of commission. For our competitive model above, inhibition could be overcome by an increase in agonist. That's not the case for pseudo-irreversible. So as you can see, when the enzyme is out of commission and it is irreversibly bound by its inhibitor, that reduces the maximum effect. In this case, we are actually reducing the effect of the enzyme and having a less efficacious enzyme. Finally, we have our allosteric model. So we have A as our agonist acting at one site, and then we also have an inhibitor acting on a different site. Similarly to our pseudo-irreversible model, this reduces the maximum effect or the efficacy of our enzyme or our drug. Therefore, increasing agonist isn't going to be able to overcome the effect of this inhibitor. Finally, if we have an allosteric potentiator, which is our little p over there, we are going to be able to increase the ability of our enzyme or drug to operate in some way, shape, or form. This will potentiate and increase the potency of our drug, therefore causing a shift to the left. So we'll continue with a couple more examples. These come directly from first aid. It's very important. There will be questions on the exam showing you these charts and then asking if you add this or add that, what will happen to the drug. So just to beat the concept home, so we have here our agonist alone. If we add a competitive antagonist, we talked about this before, a competitive antagonist reduces the potency. We still are able to achieve the same maximum effect of 100, but we shift to the right because we have our agonist competing with an antagonist at the same site. Moving over, here we are adding a non-competitive antagonist. We talked about this before. This would sort of be our pseudo-irreversible or our allosteric. It could be either one. And we see a reduction in potency. Agonist is not able to overcome the binding of the antagonist, whether it is allosteric or if it is at the same site. Therefore, you have a reduction in the actual maximum effect. Therefore, you have a reduction in efficacy. And then finally, this is sort of what I was going on about before, if you have an agonist alone and you add a partial agonist, you actually are reducing the maximum effect or the efficacy. So the partial agonist sort of, it acts as an antagonist, but it also has some agonist effect, so you will lower the maximum effect. But interestingly enough, if you look, it does cause a little bit of a shift to the left, so it does actually increase the potency. It's a little bit of an oddball. I don't think it's something for you to know. I want you guys to focus on, going back, I want you to focus on what happens if you add a competitive inhibitor, a non-competitive inhibitor, to remember those two things, because that's really what you're going to have to be dealing with. All right, and just a few more terms that are, I would say they're more important for your upcoming exam. You may see them on the boards. This is more, clinical future type stuff. So the first one is desensitization. If you have a receptor and you continually attack that receptor or give that patient an agonist, eventually you're going to desensitize that receptor. These receptors are tyrosine kinase receptors, G-coupled protein, so there's a whole lot of regulation that goes on behind them. This is sort of an adaptation mechanism. You could also consider it downregulation. And the example that I would give for this is if you have a patient who's on long-term pain medication, eventually they become tolerant to that pain medication and they need a higher dose. The pain medication will have a diminished effect over time. That's actually because with continued stimulation of a receptor, you're actually causing downregulation of its transcription, so there will be less receptors to activate. This can also happen in more quick fashion, so that would be considered tachyphylaxis. That's if you were to quickly and continuously expose a patient to a specific drug, they could actually have very rapid desensitization, which is termed tachyphylaxis. The example here is a patient you're giving a beta blocker. So this is something like albuterol. It's used for asthma. If you give somebody this and you're overly relying on this, within a certain amount of time, you can actually lose effect and have diminished effect of the agonist because of sort of diminished returns from the receptor. On the flip side, you can also have sensitization of receptors, as I said before. Now, instead of giving an agonist, we're going to be blocking or giving an antagonist to a patient. If you give a patient an antagonist, you're tricking the body into thinking that the receptor isn't firing. So the body will actually upregulate the receptor's transcription. However, if you're giving somebody an antagonist, that's fine because it will continue to be blocked. However, if you withdraw the antagonist, you can have just physiological release we'll say, of norepinephrine with twice, maybe 3, maybe 4 times as many upregulated receptors, you can be super sensitized to physiologic receptor stimulation. And so the example here is if you give somebody a beta blocker, again, the beta receptors on the heart, you're blocking the beta receptors on the heart to slow down a patient's heart rate. You'll learn all that soon enough. When that happens, you're trying to slow down their heart rate and bring down their blood pressure. Over time, that can actually cause an upregulation of beta receptors in the heart because it's being blocked. The body notices that and it starts up transcribing the beta receptors. If you all of a sudden stop giving a patient beta blockers, they can withdraw from that and have a rebound hypertension and tachycardia because all of a sudden this physiologic release of norepinephrine is causing just a rapid, it's just having a substantial effect on these upregulated receptors. So that would be supersensitivity. It's just a couple of concepts that may be tested and important to understand because it plays into like a bigger picture of giving a patient drugs and understanding why maybe a drug is losing effect or why taking a drug away can cause withdrawal. So I think one of the trickier things that hopefully we can explain is talking about acids, bases, and why certain things cross different plasma membranes. So we'll sort of talk about that question where the environment has a pH of this, your drug is a pKa of, or no, it'll just say your drug pH is this, the environmental pH is this, and then which drug gets absorbed more in the stomach or small intestine, yada yada yada. So I think just to start, we all remember from chemistry pKa and pKpH. I'm not going to come in here and try to act like I'm Henderson Hasselbalch, him or herself. However, like a very basic understanding I think can go a long way. So a strong acid has a low pKa. pKa of 1 is a very strong acid. A pKa of 10 is a very weak acid. And as you know, acids dissociate. So you have your acid in its non-dissociated form, and then you have your acid in its dissociated form, the anion and then the hydrogen ion. So we all know that when it comes to pKa and pH, the stronger acid will dissociate if you were to mix two acids together. So therefore, whichever acid is stronger or has a lower pKa is going to be in its dissociated form. Now, it's very important to remember that to cross a plasma membrane, it's extremely important to remember that the uncharged form of the acid is the one that crosses. So what we're actually trying to do is we're trying to make sure that we have a left shift in our equilibrium. So to do that, we want to have a weak acid. That's why all of these drugs are weak acids or weak bases, which we'll talk about next. We want the acid to be in an environment that has a lower pH than the drug, therefore forcing it to be in its non-dissociated form so then it can cross the plasma membrane. So for example, if we are in the stomach has the pH of 1. Do we want a strong acid that's going to be dissociated, or do we want a weak acid that's going to be in its non-dissociated form? We want a weak acid. That's why weak acids are drugs. So we want the pKa to be above the pH. The closer the pKa is, the higher the pKa is, the better it is at going to be in its non-dissociated form. So for question 1, if you have a pH of 1, obviously you want the pKa of 9, the weaker acid. If the environment is 8, you still want the pKa to be higher. The higher the pKa, the better. Just as a little memory hook, acids above, for the pKa, you want the pKa greater than the pH for the greatest amount of absorption. Just remember acids above, and later it'll be bases below. And just to sort of elaborate on this, it's sort of for people who are a little bit more visual learners, as we know, we have this acids dissociating and then the non-dissociated form. This is sort of similar to the example before. We have a pH, or sorry, a pKa of 4.4, and we have our pH of 1.4. If our pKa is above our pH, we have the ratio is much more in favor of the undissociated form, so that form can then cross the membrane barrier. And then interesting, just trying to introduce another concept that could be tested as well, is something called ion trapping. So now that you're in the plasma, your pH has jumped up to 7.4. Remember, our pKa is 4.4. Therefore, our pKa is below our pH. Our pH is our pKa. We have a stronger acid. We have an acid that is in a more basic environment. Therefore, more of it is going to dissociate. So it's trapped in the plasma. And that's sort of this concept of ion trapping. Once it crosses the lipid mucosal barrier, or the, whatever it is, the blood vessel, whatever we're trying to cross now we're stuck in this area where we sort of want the drug to go and it can distribute. All right, so we already talked about weak acid dissociation, so now let's get into weak base. And fortunately for us, they've decided to just, flip everything on its head, and everything is completely opposite for weak bases. So we're still going to be using the pKa nomenclature, however, it's flipped. A weak base would be have a pKa of 1, which it's interesting because a weak base would technically just be a strong acid, but regardless, our pKa of 1 is our weak base, and our pKa of 10 is a strong base. And we want to remember that it's a little bit different. The weak base in its non-dissociated form actually is charged, and its dissociated form is uncharged. So in this case, we want the dissociated form because that's the form that's going to be nonpolar and cross the membrane. But opposite of our strong acid, a strong base actually, it's our proton acceptor, and so our strong base will bind the hydrogen ion and force the equation to the left. In that case, we have a strong base, and we have a pKa that's greater than the pH of its environment. So in that case, as I just said, it would actually force it leftward. I'm sorry, that should be leftward. It'll be corrected in your PowerPoint presentation. So that would shift leftward, as indicated by the bolded, the bolded base and hydrogen ion. So therefore, what we are trying to do, as I had just said, was force it to the right and force it to the dissociated form. So before I had said, acids above for the greatest absorption. It fits in nicely, but we want bases below. So we want a pKa that is below the pH or closer to the pH to force it into its non-dissociated form and to cross the plasma membrane. So in the example, if you had a pH of 1, which is something you'd find in the stomach, which drug would be more absorbed? A weak base with a pKa of 2 or a pKa of 9? And that would be the pKa of 2 because it would be the weaker base. You'd have more of the dissociated form, whereas if you had a strong base, it would be in its ionized form and it would not be dissociated and it wouldn't cross the membrane. If you change the pH, the question remains the same. You have a pH of 8 in the intestines. Which of the drugs would be absorbed better? The pKa of 2 or the pKa of 9? And again, the answer is 2 because, again, we want the weaker base. So sort of at the end of this weak acid, weak base discussion, I want you to remember acids above for the greatest amount of absorption, bases below. Just repeat it, acids above, bases below, and you should be able to get through any weak acid, weak base discussion. So just a few more quick little things. Now, so these are random facts that might show up on your exam. They're sort of part of your practice problems. I wouldn't worry too much about them for the step 1 examination, but just for now, you just got to know it to get through the exam. So one of the things is that pKa and pH are represented logarithmically. Please don't ask me how to explain that to you, because all that stuff is pre-calculus and calculus in high school and is completely out of my brain. However, she may ask about the numerical difference between them, and what you just want to remember is logs are represented in powers of 10. So I believe one of the practice problems that you have, or something that was in one of your lectures, the question is, if you have a pKa of 4.2 and a pH of 8, what's the numerical difference? And if there's 4, 8 and 4 is 4. So if there's a difference of 4 between them, that's actually translated into 10,000, which is just on the logarithmic scale, because 4 zeros, 4 differences. Just remember that. And then finally, she talks about a lipid-water partition coefficient. I believe what that really is just indicating is how lipophilic a substance is. The more lipophilic, the better it is at crossing a plasma membrane. So if you have a question and the answer is obviously, let's say, a pK of 2, and then you have a pKa of 2, but you have a LW of 0.5 and an LW of 100, you want to go with 100 because it's more lipophilic, and therefore it's going to more easily distribute across the plasma membrane. It's not really something you need to know going forward after this exam, just to sort of get past this one.